introducing Dr. Sean. I have the pleasure of introducing Dr. Sean McEvoy, who's an associate professor at the Washington University and in St. Louis. So I want to thank you, Dr. McEvoy, for taking the time to moderate and coordinate the speakers for this evening, and I'll hand the baton over to you.
Great. Thank you so much. I'm really looking forward to it tonight. It's a lot of fun to have an excuse to ask people that I admire to talk for an extended period of time about questions I want to ask them about. So it's a lot of fun. Just has how the outline of the night is going to go. Our topic is going to be surgical treatment and management of spasticity and movement disorders. We're going to start out with two longer talks tonight, each about 20, 30, 35 minutes in length. There'll be time in between each of those talks to have conversations. And then after each of the longer talks, we're going to have, after the two longer talks are finished, we'll have two case presentations, one by my partner, Jared Rowland, who's going to be discussing a selective dorsal rhizotomy case, and then by our fellow, Bernardo DeMonico, who's a quite accomplished functional neurosurgeon in his own right, talking about a baclofen pump case. To start out, our first talk is going to be by Jeffrey Raskin. Jeffrey is an associate professor at Northwestern University. He's the director of functional neurosurgery at Lurie Children's Hospital, and his talk is going to be entitled Phenotype-Based Management of Pediatric Movement Disorders.
Hey, thanks so much, Sean. Let me see if this is working. How's that look?
Looks great.
Okay, great. Yeah, thanks so much for this opportunity. I was really excited when you asked me to talk about this. I think this is a fascinating topic, and I'm trying to, redefine movement disorders as we see them and all their complexity into something that's a bit more palatable for surgeons and maybe for even referring providers. So I'm interested to hear other people's take on what this phenotype-based management means. I have some disclosures, none of them really relevant to this particular talk. It's good to start, especially since you never know who the learners are, and there's always usually learners, to correlate hypertonia pathophysiology with surgery. Recall the treatment algorithm for treatment for children with hypertonia in general, and then understand the spectrum of neurosurgical management. Okay, so there's basically two areas of this talk: pediatric movement disorder framework, and then phenotype matched neurosurgery. And I'll use some independent cases to sort of flesh out what I mean by phenotype matched neurosurgery, and hopefully that will generate some area for discussion. So pediatric movement disorders in general, if you take all comers that see a pediatric neurologist and they're in the office, the very most common movement disorder is a tic disorder. The very least common movement disorder is a tremor in pediatric neurologist's office. When you talk about cerebral palsy, about 70% of cerebral palsy manifest as spasticity. And that's why we always title these talks Spasticity and Movement Disorders, or just spasticity. People refer to pediatric movement disorders as spasticity. You have spasticity clinic and so on and so forth. But it's only because spasticity represents about 70% of the movement disorders that present from patients with CP. There are other manifestations of movement disorders, including dystonia, which is about 10 to 20%, and then other dyskinetic forms. So taken together, pediatric movement disorders are a very heterogeneous group just by the manifestation of the pathophysiology. And it's worth touching on the pathophysiology just to remind everybody that spasticity is primarily a constitutively active myotatic reflex. So a lack of inhibition of those reflexes from above through the reticulospinals and the corticospinal tracts. Whereas dystonia is a lack of choosing. It's a brain phenomenon, and it's a simultaneous activation of agonist and antagonist musculature. So they're two totally separate areas, yet they manifest the same. They manifest as hypertonia. And pathologic, medically refractory hypertonia leads to muscle breakdown and fibrosis, contractures, joint dysfunction, limited range of motion, and pain, and that leads to loss of function. And the algorithm through which we treat these patients starts non-invasively and moves through injections like botulinum toxin or phenol neurotomies, ultimately into neurosurgery, neurosurgical procedures, which includes neuromodulation and permanent surgery like rhizotomy, pallidotomy, and neurotomies. One of the things that makes the treatment of these movement disorders so difficult is that there is no ILAE, right? In medically refractory epilepsy, you have the International League Against Epilepsy that recommends the phase 1 algorithm and who should enter the phase 1 algorithm as a pre-surgical patient. And that really does not exist in pediatric movement disorders. And so we did a scoping review, and we'll submit this soon, but we found only 15 studies that had any semblance of a, sort of intentional workup for different patients with movement disorders. And from this, we've sort of gleaned that we could come across movement disorder etiology, designation, et cetera, and try to understand a better way to move patients from what we see in the clinic to what we have to offer in the operating room. So the patients are heterogeneous because of their pathophysiology, and they're heterogeneous because we lack guidelines on who to see. So therefore, we see patients with severe spasticity at age 17 and at age 3, right? And so this variability lends to innate difficulty to actually draw any conclusions based on these populations. We also have no biomarkers for any of these conditions, and largely we rely on patients' clinical exams and some diagnostic tests, including genetic testing. But even this 2021 paper has considered genetic testing all the way down at the bottom. And probably we know a lot of these movement disorders actually have genetic underpinnings and should be actually more the standard of care. And then the final thing to talk about when you talk about the difficulty in identifying appropriate treatment for these conditions and patients that we see is that severity converges. So in the most severe end of the spectrum for both dystonia and spasticity, you get rigid limb. And so it's very hard to tell sometimes if that rigid limb is due to spasticity or dystonia or combination of the two, and which one might be the predominant one. And then add on to that, that these patients usually have rapidly progressive conditions and are medically refractory. They have scoliosis and they have spinal fusions to treat their scoliosis. They have multiple access tubes. They have a fragile physiology. Family expectations are sometimes out of proportion to what we can offer. And then there are also social limitations. So those patients that might be good candidates for intrathecal or intraventricular baclofen therapy, if they can't get routinely and reliably to their doctor's appointments, then they become not good candidates for that particular therapy. And then overall, there is a lack of clinical evidence, again, pointing and owing to the fact that these are heterogeneous patients. And when you take heterogeneous patient populations and group them together, it's hard to come up with logical logical conclusions from that. Again, the goal of neurosurgery for hypertonia is to decrease the morbidity, to have the lowest morbidity possible, and improve tone, improve function if possible, and improve quality of life for these patients. And so when I talk about phenotype matched surgery, I'm really referring to these two patients who have different movement disorders. The one on the left has a predominant dystonic quadriplegic cerebral palsy, and the one on the right has a predominant spastic quadriplegic cerebral palsy. But their phenotype and their motor function is poor, and it's caused by how severe each of their movement disorder is and the distribution. And it really is agnostic to the pediatric movement disorder etiology itself. In this case, they're both cerebral palsy. So I want to talk about this in a bit more detail. And we'll start with spasticity. I think from this sort of algorithm, getting you from pediatric movement disorder to procedure, you can see that diplegic, ambulatory, spastic patients have a specific therapy that I think everybody pretty much agrees on, and that's selective dorsal rhizotomy. And this is going to be really expounded upon by Neena, who's, I'm sure, going to do an awesome job. And I'm just going to very briefly highlight this idea or this concept of phenotype matched surgery. So on the left, you see here GMFCS3 patient with diplegic spasticity and scissoring walk. It's a crouched walk. He used a rear wheel walker to ambulate. And you can see a brain that is common in these types of cerebral palsy patients have periventricular leukomalacia. And recall that the somatotopic organization of corticospinal tracts have the leg fibers medial, and that's why these patients generally have diplegic spasticity. And selective dorsal rhizotomy has been applied to these patients specifically for decades, and everyone really points to Dr. Gross and his presentation in the 1960s, where he showed that selectively sectioning the dorsal root in these patients would lead to improved outcomes. And so that's where we get essentially this diagnostic criteria that almost everybody agrees on, which are children ages 3 to 8, spastic diplegia, strong core, mild or neurocognitive delay, so that they have strong rehab potential. And then there are randomized control trials and a meta-analysis that suggests that with SDR plus PT, that we have very good outcomes in improved independence and decreased tone. And over time, there has been surgical iteration by our late T.S. Park and others who have gone from big bony exposures to little teeny bony exposures. I'm sure we're going to hear more about this. This is how I do it. This was just one very focal case. Left L5S1, this is L5, and a patient with a DNET trying to fix the plantar flexion. And so we isolated the nerve root, which looks like the top left, where you get stimulation in L5 predominantly. And then I do a super selective rolling T.S. Park method, where if it activates just the expected myotome, it gets saved. And if it activates adjacent or contralateral myotomes, then it gets cut. And then using that methodology, you get improved ambulation status. This is at 6 months. You can tell the child after surgery is just running laps around his preoperative self. You can tell also there's a lack of scissoring. His gait is less crouched, and he's overall quite improved in his ability to walk long distances. So that's an example of what I mean by phenotype-based. Of course, diplegic spasticity, we all agree, or most of us agree, that cerebral palsy patients, those are clearly indicated. But what about spinal etiologies like transverse myelitis and spinal cord injury patients? Those patients are a bit more controversial in their indications, but I would submit that the vast majority of them, based on their phenotype of ambulatory diplegic patients, should be offered such a procedure. And I think that there's ample evidence suggested by Sam Browd and Albright, and I think Brandon Rock as well, manuscripts in the literature suggesting that phenotype also does well after SDR. Well, I'd like to move to dystonia, because this is a very complicated and interesting set of diagnoses. And I think if you consider that there's what we commonly refer to as primary dystonia, or TOR1A, and then secondary dystonia, which we all believe is acquired or structural, that there is a group that is left out. And I think that those are some heredodegenerative conditions that have been redefined as primary dystonia, mostly because they respond to deep brain stimulation. And so when you see this large group of included genetic isoforms that are responding well to deep brain stimulation, you can see that there's a clear difference between primary and secondary dystonia. In this case, it doesn't make sense to talk about a phenotype because these are really genetic diagnoses. But primary dystonic patients, just to point out, they do phenomenally better than secondary dystonic patients, with primary dystonia patients really outperforming secondary dystonia patients when you talk about deep brain stimulation to the GPI, as well as pallidotomy to the GPI. And this is an example of DBS case. This is how I do it with a robot. I don't do any microelectrode recording. What we rarely talk about in neurosurgery is what these exams look like. So I'd like to highlight this. Patient has left arm extension, right arm flexion, retrocollis, that's asymmetric, a crouched gait, and obviously needs assistance to ambulate. He started normal as a 8-year-old, like 0 to 8, totally normal, and then started with a foot dystonia that progressed. And ultimately, he got testing, was diagnosed with primary dystonia with TOR1A, and got deep brain stimulation in 2 stages, as is routinely done. And this is after surgery when he's turned on at 6 months, ambulating down the hall with a little bit of a dystonic catch, especially in his right leg, but able to walk backwards and forwards, and clearly much, much better. When you talk about secondary dystonia, things get a lot more murky. Primary dystonia, deep brain stimulation is extremely effective, and pallidotomy in under-resourced areas and institutions is also very effective. And they're both more effective in primary dystonic patients than in secondary dystonic patients. But in secondary dystonia, pallidotomy is still an option. There's a fair amount of literature on this suggesting that pallidotomy is better than thalamotomy in adults and children, and that pallidotomy can be associated with bulbar dysfunction, including swallowing and breathing dysfunction. So bilateral pallidotomy should be reserved for pretty much the sickest patients, especially if they have secondary dystonia. If they manifest as status dystonicus, it has shown to be life-saving and very effective. But in the absence of that, probably deep brain stimulation, intrathecal or intraventricular baclofen, or ventral dorsal rhizotomy, if there's an opportunity to not treat a global picture, but to treat more of a segmental picture. And that brings me to the most severe manifestation of dystonia, which is status dystonicus. Status dystonicus, although we all pretty much know it now in our lexicon, was really only clearly described in the literature in 2007. And it really is the final manifestation of dystonia and frequently precedes death. Especially in patients who are routinely and recurrently admitted to the ICU, despite many different medications and so on and so forth. So this is something that should be treated pretty aggressively. And there's multiple ways, and I would submit to the group that pallidotomy is a very underutilized approach to those patients, as is intrathecal or intraventricular baclofen. A lot of these patients get DBS, which probably is effective because of the initial lesional effect of placing electrodes in the GPI, but ultimately it has a very high infection rate and complication rate, especially in these status dystonicus patients. Intrathecal baclofen is an important therapeutic measure for us as functional neurosurgeons who treat patients with movement disorders. It has a testable effect, and that should be taken advantage of, especially in patients where they have a mixed movement disorder or poor head control, and you're worried about a head drop. That's a good way to use, bolus testing or continuous testing in the hospital. And then if the family is not yet convinced that it's a good idea, then that's another good reason to do a test dose. What we're trying to get away from is insurance companies telling us that we need to do it, because there is a complication rate associated with putting patients under anesthesia, or however you do it. Doing procedures to these children with fragile physiology can and should be avoided. The indications strictly are spasticity in patients over 4 years of age. We use it off-label for patients with dystonia or mixed movement disorders. But the clear indications are first, the management of spasticity in patients age 4 and older. And it was approved in 1984, which I think is useful for everyone to remember. Classically, we put these pumps in patients 40 pounds and above, but smaller is sometimes possible. And then there are very few surgical contraindications. Access points to the cerebrospinal fluid space include cervical through C1-2 puncture, ventricular through Coker's point or any other point that makes sense, and then, of course, through the lumbar cistern. And I think I was highlighting status dystonicus. This is a status dystonicus patient who has Leigh syndrome, which is a mitochondrial myopathy, and the patient was on palliative care, has severe dystonic crises, including her entire body, face, spine, etc. You can see her activating all muscles here. And she was extremely hypersympathetic with hyperthermia, tachycardia, hypertension with Barry-Albright dystonia scale of 36 and a CK elevation despite multiple medications. And this is the progression of her imaging. You can see T2 signal throughout the basal ganglia over time. And so I talked with the family about what they wanted to do. They did want to proceed with something, so we put an EVD in place. And due to her dysautonomia, I decided an EVD was a good idea instead of just a cervical catheter. And she did really, really well. So we replaced that EVD with this intraventricular pump. There's two things that you want to do if you do intraventricular baclofen, which is well supported in the literature by multiple large case series. You want the catheter to stay. So either put it in with an ultrasound and use the DBS burr hole cover, or use the short spinal segment and then sew it as you see the catheter collet behind the ear. You sew it down to the fascia, or you do both. And I've never had one move if you do both. And these are really effective ways to manage both patients with secondary dystonia, with mixed hypertonia, or patients in status dystonicus. And there's, again, a large literature out there. This patient had an immediate reduction in her Barry Albright dystonia score, CK, all of her vital signs, and went home and never came back to the hospital, as is represented in the literature through these papers by Mike Turner, early adopter of baclofen, intrathecal baclofen therapy, and of course our own Dr. Albright and team, who have defined maybe even a fewer complication rate with intraventricular baclofen compared to intrathecal baclofen. Very effective strategy. It's sometimes hard to get families to buy in to that strategy, but it is usually very effective. Mixed hypertonia is the simultaneous presentation of, some dyskinetic or dystonic form in addition to spasticity. And these patients can be pretty complicated. And this is a patient here who has all these access tube issues and had a pump that was failing, has obviously non-decremental clonus of the arms, decremental clonus of the legs. And the question is what to do with this patient and the pump that needs to be replaced. In this case, I tried to wean the pump, but it was not possible due to short gut syndrome. And so we put a new pump in the chest, in the pectoral region, and then the catheter in the C1-2 through a C1-2 puncture to C0. It's just recently published. This patient did great. Sometimes you have to get inventive, but I think I wanted to underscore there that there are patients with surgical complexity, and then there are patients with movement disorders and problems, and that we should try and endeavor to take care of them no matter how hard it is. But you get these other patients who have, brains that look thusly along the top and are more globally affected. And this is the exam from these two patients I showed at the beginning of this talk, where they have sort of similar phenotypes, meaning they're both quadriplegic, hypertonic, both have CP. But this child on the left has more dystonia than spasticity. You can see there's a small catch, but the toes you're going to find are curling significantly, and there's no reflexes there. And this patient has pretty much profound dystonia throughout, whereas this patient, which I've already shown, has significant hyperreflexia and spasticity. And I'm not sure he has any dystonia at all. But for both of these patients, if the goals of care are to reduce the tone in the legs to provide more hygienic care and decrease hip dislocation and pain associated with that, then lumbosacral ventral dorsal rhizotomy is the right choice because it's for tone control. A lot of people call this SDR, which I just fulminantly disagree with because I'm not sure what you're using to do ventral, like selection of the ventral roots. And also there's no need, adding selectivity is intended to improve function, to provide a gain of function surgery, whereas doing ventral dorsal rhizotomy is intended to maximally denervate the extremities. And I think this is safe. We published this recently and looked through the literature. There were 3 very nice series describing variability in bone opening, extent of dorsal rhizotomy, extent of ventral rhizotomy, and the use of selectivity, which I don't really understand. But regardless, we added ours to the literature as well and found similar improvement in Barry Albright dystonia score, as well as independent patient analysis of modified Ashworth scale. And we make it through a little incision. It's very similar to selective dorsal rhizotomy, except without the selectivity, importantly, and with ventral rhizotomy. But there are some patients who have spinal fusions, et cetera, that just aren't amenable to this sort of approach. And so we started trying to think, what could we do for those patients? Well, in the 1970s, before the baclofen pump was invented, radiofrequency ablation was a common surgery that was performed particularly for patients with spasticity following trauma and spinal cord injury. And this is pretty straightforward, but this is not. So if the spine is rotated and they have a fusion, how are you going to get there? And so we paired sort of the brain lab technology with a bone marrow biopsy needle and then a radio frequency ablation electrode that goes through that. And this has been an effective strategy for those patients who have very restricted corridors and open ventral dorsal rhizotomy is infeasible. We found a variety of issues here with the placement of the array, the length of the needle, using a depth mark, et cetera, that were worked with the innovation group here at Northwestern University and have a patent pending for sort of a peel pack kit that might be more effective for this particular approach. But there were even these patients who had complete rotational anatomy, and you can see there's absolutely no corridor in the left there between the ribs and the rods. And so the question is, what can we do for this patient and patients like him? The family refused a baclofen pump and didn't have the social ability to come to those appointments. And so it sort of drew on past experience with endoscopy to fenestrate ventral spinal arachnoid cysts and try to solve these problems on visibility, selecting the myotome, and then performing an ablation, and put together this surgery that we've done several times now called endoscopic rhizotomy, and endoscopic ventral dorsal rhizotomy, where we drill a hole in the spine, so heterotopic osteotomy, and then introduce the camera. This is a flexible endoscope, and then, going north, we can look towards the spinal cord and identify these nerve roots. From a visibility perspective, there's two things. One is clarity of spinal fluid, which is very clear. The other is identifying the nerve roots. Now you can see those nerve roots because they're on the concave area, but you'll see when we get to the other side, the convex area is very hard to see. And they're actually blocked by the dura and the curve itself. Second thing is trying to get the nerve root to tell us what myotome it innervates. Not always possible using our current techniques, but we are able to stimulate this nerve root and get a reliable response if we stimulate it aggressively enough, not by doing that, interestingly, but actually by putting the scope itself into the nerve root. And that may manifest from these muscles and nerves being extremely sick and fibrotic. Actually probably need something else to get an appropriate activation of the myotome. I'm going to skip ahead. So here you can see when I talk about visibility on the left side, or the convex part, it's very hard to see the nerve root when you're looking up because it's already kind of exiting and you can barely see it. Furthermore, there's no way to defend yourself against passing nerve roots. So in order to make sure you're at the right spot, you can use this fluoroscopy, which we were set up for, to make sure that we were at the appropriate level. That was L2. And then finally, I want to show what it looks like when you point down and look south. So you can see all the nerve roots kind of exiting together. You can also get into what we're calling the axilla of the nerve root as it exits, and you can really stimulate those nerves with great reliability. They're also very visible. It's very uncommon to have a curve in the sacral spine, right? They're usually in the lumbar thoracic spine. So I think pointing down is probably the best way to do this surgery in the future, and we're still kind of figuring this out, but I wanted to share it with everybody. This is the end result of that surgery. These children, they do very well, and they go to inpatient rehab, and their mobility is better, their pain is better, and we have 3 months of data follow-up on these patients. This is really my last slide. I didn't get to talk about brachial hypertonia, but I want to just highlight the fact that this is another strategy. So you can pair lumbosacral and cervicothoracic ventral dorsal rhizotomy for patients who have quadriplegic hypertonia, either dystonia or spasticity, and get a really good result by decreasing the tone. And what we're seeing here on the right is a patient who actually is a GMFCS1 patient, but had profound left hand dystonia, and we did a ventral dorsal rhizotomy for him from C6 to T1 and got a great confirmation of his hand. So I think that overall, patients who need to be referred to movement disorders for us to at least evaluate for one of our many surgical procedures is any pediatric movement disorder that's rapidly progressive, medically refractory, or related to pain. Any primary dystonic patient or patient with status dystonicus, any tremor patient, any spastic patient with ambulatory diplegia, and then mixed hypertonia is a grab bag. These are the main patients that are just like there are no guidelines on who to send to us and when to send them to us. And so I think we need to work on that as a group. Future innovation, we can move from right to left. Comparative studies, I mean, there's just a profound lack of comparative studies for many reasons. Maybe we'll talk about together at the end of this. We need to standardize referral guidelines. And then my own personal interest is in applying rhizotomy, the endoscopic rhizotomy to the cervical spine to decrease brachial hypertonia, to create a better stimulator of nerve roots, namely a flexible endoscopic bipolar stimulator, and then develop some way to discriminate ventral nerve roots, like maybe ECAPs, like we're using in spinal cord stimulation for pain. I'm the functional neurosurgeon here at Lurie Children's, and we do a fair number of functional cases this year. 70, it'll be 73, but it's 71 right now. And then of course I find this work really rewarding and inspirational, and I couldn't do it without my exceptional partners. I thank them all for letting me do this work, and thank you everybody for listening. And I'm happy to answer any questions now or in the future.
Well, that was a wonderful tour through pediatric functional neurosurgery. I think about any one of those slides could be turned into an hour-long talk for everybody to listen to. So that was a lot of fun. One question I had to just get things started, particularly for the trainees, is you talked a little bit about intrathecal baclofen pumps, and sometimes deciding where you're going to leave that catheter at, even if you're going to be in the spine, is a big decision-making process. If someone isn't cleanly affected only lower extremities, they maybe have Mott, their upper extremities are affected, they have some function in it. How do you decide where you're going to leave, who you're going to leave it? T10, C7, upper cervical spine, intrathecal. Do you have an algorithm that you go through?
Yeah, I think if they have any dystonia, then I like to leave it in the cervical spine. It recently published like 25 straight cervical spine tips, and with with actually one complication, a patient went on 2,400 micrograms a day, was too much for the cervical spine. But besides that, if they have any dystonia, I put it high, like C something and above, maybe C5 and above, and then. If they have like pure spasticity and the family is really focused on the lower extremities, it's really the only time I'll leave it at like T10. But otherwise, I go for the cervical spine in almost all other cases.
Any other questions, or people are free to type in the chat as well.
Hi, Dr. Jeffrey. Awesome. Your lecture was very nice. I've been doing spasticity for almost 10 years, and I have done most of the procedures you showed there. And my experience doing RFA to spasticity, I have a few patients I've done like spinal cord injury, as you said. My concern is if you're doing RFA to patients who has preserved sensibility, aren't you afraid to develop like a nociplastic pain, or like, what are your thoughts about it?
Yeah, that's definitely a concern. I mean, I think that these are not salvage therapies for patients who've had other nerve injury, like intentional or otherwise. So patients who've had peripheral neurotomies, or any sort of like SDR, and then you're trying to touch up a nerve with radiofrequency ablation, you run the risk of inducing an untreatable neuropathic pain syndrome. And even in the absence of that, you can't know exactly how much of the nerve you're ablating, particularly the dorsal root. And so I think this is one of the reasons why the endoscopic technique might allow you to regulate the amount of destruction that you're performing from the central location under visibility. But yeah, I have those concerns as well. And currently, there's no way to rectify them coming from a peripheral approach.
Dr. Raskin, one thing, if you could just expand a little bit more on, so obviously interventricular pumps, not really, you don't see it much. So if you can just, for the trainees as well, just kind of go through where you spoke a bit about the DBS burr-hole cover, but if you can speak about where the pump goes and how that's regulated, I think that would be useful for our trainees if they
Oh,
haven't seen it before.
oh, sure. Yeah. So you want the catheter to be either in the foramen of Nerow or the third ventricle or the lateral ventricle. There is actually some historical controversy on what's better, but I don't think it actually matters. You just want it to be in the ventricle, right? And so it's more of a shunt surgery, patient supine. You can put the pump in the same subcostal incision, or you can put it in the chest, depending on the size of the person. And then, tunneling works the same. It's just making a 14 millimeter burr hole using a perforator is key if you want to use the burr hole cover that comes from, Medtronic or whoever else sells DBS electrodes. And it's the same DBS, system. And so I would make a burr hole, put that 14 millimeter DBS lead holder on there. I can't remember the name of it. And then either use an ultrasound to gain ventricular access and put the catheter, the spinal catheter next to it, or use stereotaxy and a slotted cannula, and then, get into the ventricle and put the catheter in place. So those are the two ways to put it in that are reliable. I've done both. I think the ultrasound is fine. And then you secure it on the burr hole cover and then tunnel it back, down to the pump. It's a pretty straightforward surgery.
Okay, well, I think we'll move on to our next talk. So Dr. Marupudi, I've been lucky to learn from some time. She was the fellow in Seattle when I was a chief resident, so I've been lucky to have her advice for quite a while. So I'm excited to learn about how she manages selective dorsal rhizotomies. She is an associate professor at University of Michigan and director of pediatric spasticity at Mott Children's Hospital in Ann Arbor, and she's going to be talking to us today about her selective dorsal rhizotomies techniques and indications.
Thanks so much, Dr. McEvoy. Can you guys see my slides okay? Does it look like a single screen?
Yep, up on one screen.
Awesome. Well, I love the opportunity to do this in conjunction with Jeff Raskin. I feel like we're two peas in a pod. And so while I'm going to focus on selective dorsal rhizotomy, I love a lot of the cutting edge and even some of the older techniques that are being brought back to care for really complex patients. So I'm going to hone in on selective dorsal rhizotomy and share with you what I think are the evolution of the technique and really the evolution in the indications as well, which again, Jeff had touched on a little bit. So I have also a few disclosures. For a long time, I didn't have any, so this is really nice. I'm a consultant for Integra and for Monteris, but this has nothing to do with this talk, so I'll move on. The goals for this talk are, we're going to talk about, again, the techniques and indications for selective dorsal rhizotomy, but I really want the trainees and even our panelists to understand the considerations, the indications for selective dorsal rhizotomy. You will see that we have a historic pattern of patients we feel are good candidates for SDR or ventral dorsal rhizotomy, but we want to expand this palette and we want to expand these indications. And then I also want you to recognize some of the advances we're making in the less invasive techniques. And you've just heard about endoscopic and radiofrequency ablation. And I'm going to talk about just smaller incisions and how to make this work with better monitoring. So I get to fly through these slides because Jeff did a great job of talking a little bit about what is spasticity, but I just want to highlight again, spasticity is velocity-dependent tone. And what we're seeing is this is a disruption of the upper motor neuron pathways at the cerebral cortex, brainstem, and spinal cord. Now, in our pediatric population, spastic cerebral palsy is caused by damage to the motor cortex, but this can be related to infection, stroke, prematurity. We're really going to see a wide variety of causes for cerebral palsy. And we're kind of going back to this phenotype based approach that, again, Dr. Raskin touched on, and how this is going to impact how we make our clinical decisions in terms of what surgical options are going to be good for these patients. The pathophysiology of spasticity. I love this image. It really simplifies it for me. I really found it hard in my training to understand what is spasticity versus dystonia and this huge gamut of what is hypertonia, but really focusing on spasticity. What it is truly an imbalance between excitatory and inhibitory impulses to the alpha motor neuron. So due to the lack of descending inhibitory input to the alpha motor neuron, you get spasticity. So what are the goals of spasticity manage? Obviously, we want to decrease spasticity. We want to improve functional ability and independence. But also there's some of the palliative approach of decreasing pain that's associated with spasticity. Many of these patients can have a very high pain tolerance because they've been living with hypertonicity all their life. We also want to prevent or decrease the incidence of contractures because this affects their functionality, but it can also affect the ability of a caregiver to change clothes, to be able to feed and bathe. So we want to facilitate hygiene with spasticity management. We also want to improve ambulation if a child is a candidate for potential ambulatory abilities. Ease rehabilitation procedures, and also, which is very important, these are patients many times that require high levels of care, both from caregivers as well as hospital staff, as well as from their own parents or providers and household caregivers. And this is a really important thing in order to facilitate the small amount of time we have in each day. So sharing with you what is a classic spastic diplegic gait. This is one of my little friends. He's 4. He's on the gross motor function classification scale. He's 3. He had really great therapy support, even from a very young age, an incredible family that was very supportive. But what you see here is toe walking. He's scissoring. He's crossing his toes in front of each other. He's catching one foot behind the other. So this was a child that we really considered selective dorsal rhizotomy on because we want to decrease the lower extremity tone, improve his lower extremity strength, improve standing, balance, and posture, and also improve his ability to ambulate with maybe assistive devices or even without any devices in the long term with the continued and extended rehabilitation. Now, how does selective dorsal rhizotomy work? So we know there's abnormally responding sensory rootlets, and that these are the ones that are contributing to spasticity. And by eliminating or reducing these rootlets, and in essence, cutting them or ablating them, you decrease the tone and improve the motor function. These abnormal roots are the ones that have less inhibitory control. So when we do monitoring, we see an abnormal sensory response. The abnormal roots respond, the abnormal motor response that you get is kind of an indicator of to what degree these rootlets may be involved in the extent of hypertonicity or spasticity that the patient is experiencing. There's typically selective ablation of the sensory nerve rootlets that are done from the L2 level down to S1. Sometimes I also go up to the S1 level and monitor this. One of our theories, at least in some of the research that we've been doing here at University of Michigan, is that, the changes in the brain as a result of infection or stroke or prematurity and the cause of cerebral palsy, it also may change the patterns as to where some of these nerve rootlets are targeting in their distal location. So while we may believe that L2 is your adductors, that's not always entirely true. It may be that some nerve rootlets from L3 or L1 and other zones may also be contributing to that. So the monitoring piece is something that I've been very interested in and gathering a lot of data on to assess, is it always a textbook pattern, or is this a really important tool for us to further explore? So the historic beliefs, and I say historic, but this is our classic and the SDR patients that we're really excited to see and care for. This is a patient pre-op, and you can see post-op just a few months later, the incredible change in the ambulation. We're looking for children that are 3 to 7 years, 3 to 8 years. This is because there's neuroplasticity and there's orthopedic implications. If we do these procedures far later, the contractures and hypertonicity are already making changes in the joints and in the knees and in the ankles. And really, the maximum functional capacity for GMFM is reached by age 5 for all GMFCS levels. So we want to stay in that zone. Most commonly, we do selective dorsal rhizotomy in the setting of CP, but as you'll see, we're going to talk a little bit more about other types of reasons to do selective dorsal rhizotomy or ventral dorsal rhizotomy, and in cases of brain injury, spinal cord injury, spasticity, and other unknown etiologies as well. So again, patient selection continued. We want, for selective dorsal rhizotomy, purely selective dorsal rhizotomy, we want spasticity to be the predominant pattern. We like for the kids to have good strength and motor control, and spasticity management is maximized maximized without optimal response. So intensive therapy program is needed, and if you don't do an intensive therapy program afterwards, you might not get your optimal response. You may get reactivation of some of the contractures or shortening because of the tightness that was there previously. There's orthopedic considerations, is range of motion adequate? Is there any hip dysplasia? So this is kind of a battle. If there is changes in the like orthopedic implications or hips or joints, is SDR a good procedure or not? And as we continue to do further research on this, we're seeing that it could still be a great option in many of these patients in order to help prevent further progression of orthopedic implications and considerations. Typically, we want patients to have good follow-through with the postoperative care plan, but we also see that patients who undergo rhizotomy have a little bit less difficulty in terms of their long-term care from the standpoint of not requiring repeated baclofen pump replacements or drug refillings. This is kind of a balance we're looking at. And in some cases, the patient may be a candidate for multiple procedures, but what is right for the family and what is right for that child is very dependent on what the global infrastructure that is around that child as well. And this is something that is very patient-specific, and it cannot be a one-size-fits-all pattern in terms of discussion and detailing to what a family what the recommendations may be in terms of their clinical care or their recommended procedure. So historically, Peacock and his colleagues in 1987 described this multi-level laminectomy from L1 down to S1. And this was a really lovely procedure. The dura is open, you do the rhizotomy, and there's a degree of sectioning that's based on monitoring. And then finally, you'll do the laminoplasty and replace the bone as well. And the issues with this are that there's a great deal of muscle exposure. It does require a pretty extended period of healing. Nonetheless, the outcomes were really good and patients benefited. And if they hadn't, we wouldn't be here expanding off of this platform and off of this base. One of the complication concerns with this was that with a multi-level laminectomy, there was a higher risk of kyphotic deformity, but not just kyphotic deformity, but scoliotic deformity or lordotic deformity, but just generally speaking, deformity in general. And that's a pretty expected thing when you're doing multiple levels of the lumbar spine. Now, Dr. Raskin also presented this paper. We love this paper. I think the beauty of this is it's just, we're looking at all these different techniques that people do in these variations. And this paper really nicely brought together these illustrations, starting off with Peacock in 1987, then Dr. Park's description in 2006. We also have Sadhu and Georgioulis who presented this like 2 to 3 levels of interest and then going in these interlaminar keyhole approach. And then Funk and Haberl that talked about this single level laminoplasty. And then Dr. Browd, Bales et al. In 2016, Sam Browd does this technique of like one level laminectomy without a laminoplasty. And this is another approach by Warsi et al. Now, I'm going to talk to you about my approach too, which is a no bone removal and kind of an interlaminar approach. But I will say that all of these approaches, you get an incredible result from them. So I think I have a passion in moving towards less invasive approaches. And with the tools that we have, we're able to do less and less exposure and still be able to achieve greater and greater results. And you saw that in the last talk as well. So just a reminder, the traditional and original approach of the multi-level laminectomy, laminoplasty is still used quite extensively. And I make the joke of calling it maximally invasive, but it's really quite lovely, really beautiful. You can see a lot of the nerve rootlets, but there's some negatives to it. And those negatives include pain, spinal deformity, scoliosis, and kyphosis. And one of the things I think that has drawn me away from this approach is that there is some limitation in the immediate postoperative period where you cannot aggressively rehab these kids because they are still healing. So we know SDRs work, and if you could do it by reducing the risks to the patient further, why not? So we talked a little bit again. I just want to highlight some of the spinal deformity in the SDR techniques, even with multiple level or even full laminectomy at 1 to 2 levels. Remember, all of us have done spine surgery. The paraspinal muscle elevation can be quite painful, and what it does is it can delay some of the core strengthening that the kids can do right after surgery. Laminoplasty is often frequently used to reduce this instability, but you're still unavoidably interrupting the interspinous ligaments, and sometimes the inconsistency in some of these papers and the results that we see may be because, yes, we are still disrupting the interspinous ligaments. And scoliosis and kyphosis, even if this is mild, we already have a child that is having difficulty walking. So this can contribute to even subtle balance alterations that in a child that already has a gait instability makes things even harder, that including like hyperlordosis and spondylolisthesis. So no matter how you spin it, if any of us were to be cut open to this length, and this was somewhere between 3 to 7 years old, it's still a lot to tolerate. Now, kids are incredible and they can tolerate a lot, but I think it should be our goal to continue improving on this. So these are some stats on spinal deformity. We still see about spinal deformity in about 16 to 17% of cases, greater than 38% of incidents of kyphotic deformity following SDR. And lordosis greater than 50 degrees following SDR was found in about 7 to 17% of patients. And the incidence of spondylolisthesis is 6% to 24%. So this is spinal deformity. And we can't just bank on, oh, well, I don't see a lot of kyphosis. We may see other types of deformities in addition to or separate from kyphosis as well. So selective dorsal rhizotomy and postoperative pain. I just put this slide in because this is also important when you're doing longer incisions or doing a more invasive approach. Of course, we're going to need to use opioids or IV pain medications. And I think the idea is if we can do things less invasively, we may be able to mobilize a child faster and also use less intense drug therapy as well. So just kind of flowing through this, these are, again, the slides of the different approaches. And I'm going to highlight a few of the techniques that now have brought us to this less invasive approach. But before doing that, some of the goals of reducing surgical footprint, again, highlighting we want less pain in the kids, and we want to try and reduce or even come up with a procedure that may completely remove the risk of spinal deformity. And the other piece is it's lovely when these kids can participate in a rehabilitation immediately. And this is one of my very first rhizotomy kiddos. And you can see the videos are not even all that great anymore because I think I did this with with my phone camera, trying to get just the foot pattern. And as the months went by, we got better videos of all of our children. But you can see this is at 3 months post-op. And then this is at 9 months post-op. And I can't get her to cooperate. She's just got a mind of her own. I'm telling her to walk slowly, and she's walking slowly and deliberately, but she can actually run at this stage. So these kids are really cute. They're a lot of fun. And I think it's really important for us to think outside the box. In 1993, this is Park and Johnston's method. A lot of people have adopted this. I know that Jeff Raskin mentioned his technique too, which is quite similar to T.S. Park's method. We have Sindow et al. That use this keyhole interlaminar dorsal rhizotomy, but it's still a pretty lengthy incision and requires a fair bit of or significant amount of muscle disruption. But it is also a nice technique where you're not disrupting all of the bone that is in place as well. So this is another alternative. And then the technique that I've kind of balanced my practice off of is what I learned in my fellowship in Seattle. And this is this infraconus single level laminectomy for selective dorsal rhizotomy, where just one level of a bone is removed. But again, this is done below the level of the conus, where we have access to all the nerve rootlets, and we just look up to identify the rootlets of L2, exiting L2 or L1. And we really heavily rely on neuromonitoring in order to identify abnormal and normal. And we're learning that, well, I don't know if we're learning this, but we're still trying to figure out whether we call this selective dorsal rhizotomy, but do we need to be so selective? And is all that we're selecting for just our anal sphincter monitoring? There's a lot out on this that we are still debating and trying to learn more about, but we hope in the next 2-3 years we'll have enough neuromonitoring data to help us through this process. So these are some of the images from Dr. Broud's technique, but I wanted to just highlight the technique that I use, and this is the interlaminar infraconus mini laminotomy approach, and sort of came up with it after my fellowship with Sam Broud. Coming in between. Now, while I disrupt one of the interspinous ligaments, I don't take off all of the spinous process, and I certainly only remove at most a couple millimeters of the lamina above or below, and I come interlaminar, much like many of us do for perhaps like a tethered cord release. And while it does require a lot more microsurgical technique, all of us would be perfectly capable of doing this because we've done much finer surgery than this. This is a small opening, certainly less muscle elevation, reduced bony removal. So the kids really improve or get better from a pain standpoint much faster. And 3 days after this procedure, I have them with the full rehab without any restrictions. So right now, we continue to do assessments of their spasticity, pain, doing long-term analysis for any spinal deformity, kyphosis, bowel bladder dysfunction, any infection or CSF leaks. I have a small number of patients, but thus far I haven't had any, and knock on wood, any deformity cases as a result of this technique. So more time will tell. So it's about a 3 centimeter incision. I remove the ligamentum flavum in the interlaminar space, and if necessary, I do just a small laminotomy, just a few millimeters above or below, and then wrap all of the nerve rootlets around the blue background piece, and then keep track of them. And you can see the incision is pretty small, hardly perceptible, and this is really nice. Families really love this, and they love showing it off. And you can see just from the instruments, this is just a 7 suction. And you put this blue like background piece around all of the nerve rootlets, and we suture it to the edge of the dura. This allows us to keep track of each of the nerve rootlets, and as we pick them up, we'll stimulate them. We'll see how abnormal they are, and after, if they are abnormal, or even if they are normal, but they're reaching a target muscle group. So much like we were talking about like a phenotype-based approach, I do a patient-specific approach. So I look at the patient, we evaluate the patient with our PM&R colleagues and PT, and we assess to see which muscle groups are the target muscle groups. As we're going through these nerve rootlets, we make sure that we're hitting these target muscle groups. It could be adductors and hamstrings, and I'm told, please don't touch their hip flexors because they would get very weak. So we try our best to preserve the nerve rootlets that are stimulating in the hip flexors. Many of these patients do have a lot of issues with their gastrocs, and plantar dorsiflexion is really, really the main issue. And I think historically, there was a lot of resistance to cut nerve rootlets that are around the S2 level. But here we routinely go after these nerve rootlets and are quite aggressive with them and see excellent results without any issues with bowel or bladder function. So then moving on to new considerations in the surgical care of these patients, I want to talk about palliative selective dorsal rhizotomy. And I don't even know if this is the right word. In the Cerebral Palsy Research Network, we've really been debating a lot about whether we call this palliative or not. But for now, this is the term I use, and I'm open to suggestions to change this. But we also are looking at doing selective dorsal rhizotomy for, quote, palliative measures, where maybe a non-ambulatory child, but could potentially benefit immensely, and is just not a great candidate for an intrathecal baclofen pump. The other option is the ventral dorsal rhizotomy. Patients just want to have complete removal of these contractures and relaxation in their lower extremities, and this is a really great tool for that. And then the other thing is thinking about combining SDR with baclofen pump placements. So is SDR just for ambulatory patients? I think in the traditional surgical treatment for GMFCS4 and 5 patients, we think a lot about baclofen pump. But nowadays, we should consider SDR, even in patients with mixed tone. They may not have that much dystonia that's going to be unleashed by doing a spasticity surgery. So the benefit, I think, of thinking about selective dorsal rhizotomy or ventral dorsal rhizotomy in these patients is if patients require regular follow-up and they can't get there, they live too far from a hospital facility and they cannot come if they're having a baclofen withdrawal or overdose crisis. These are patients to consider alternative surgical options that are more permanent, but still have a long-lasting effect for hypertonia. Now, this is one more thing I want to just keep emphasizing. I don't think SDR should just be for ambulatory patients. It's what is truly the correct surgical intervention for a patient with GMFCS4 and 5 status. I mean, they have profound lower limb and upper limb hypertonia. Sometimes they have missed forms of hypertonicity. They have severe mobility constraints and a lot of pain from fixed contractures or deformities. And their caregivers are often telling us about care and hygiene constraints. So we have to think outside the box. What are we losing if we're going to be doing either a selective dorsal rhizotomy or a ventral dorsal rhizotomy for these patients? So there's a number of papers that have come out. The volume of these papers is still pretty slim. I think this is a review paper that looked at 27 articles, but only one was a paper that was comparing SDR to ITB. So we're looking at non-ambulatory patients and what their surgical treatment should be. So we don't have any randomized trials or even retrospective studies that are really large and significant in order to assess this. We have one that we are working on through the Cerebral Palsy Research Network, which will be a multi-center trial. So if you're interested, please reach out to myself and we'd love to include you. But there's just basically a lack of evidence that compares what the outcomes of intrathecal baclofen is to SDR in this non-ambulatory population. We do think this could be overcome with the standardized prospective studies or even a standardized retrospective analysis. So we're going to work on more robust methodology and these relevant outcome measures to see where we are going to be with this. And so this is that one paper that actually compared intrathecal baclofen pump insertion to selective dorsal rhizotomy from George Ibrahim's group. And what they saw was that patients in the ITP group were older. They had a lower baseline functional status and greater burdens of spasticity and dystonia. And children who underwent SDR had lower gross motor function classification system levels and were less likely to experience complications than those who underwent ITB. But there is a big discrepancy in the age, and that doesn't make this a real great clinical analysis for us to be able to still apply to patients. But I think generally speaking, a lot of surgeons are moving away from baclofen pumps just because of the hassle of their management in some of the patients that are critically ill. And at the same time, while there's an excellent role for this, I think this multi-idea approach and mixing modalities for surgical care is going to be really important in these patients. So I also want to briefly just mention there's another reason to think about selective dorsal rhizotomy or ventral dorsal rhizotomy, and this is an advancement of speech and breath control. So we have a population of patients that we were looking at to see, just throwing a speech pathologist in there to say, hey, do you see an improvement in this? And so we were looking at something called maximum phonation time, and how that's basically how long a patient can sustain a measured vowel. And we actually saw that there was just incredible improvements in the maximum phonation time. We also, at the same time, were looking at upper extremity or basically upper extremity ADLs and occupational therapy evaluations too, to see, do we see some improvement in tone in the upper extremities when we do a selective dorsal rhizotomy or ventral dorsal rhizotomy? So these are what we call suprasegmental effects, and I think it's kind of a made-up term. We don't know why patients have this. There's a number of theories as to why from baseline to 6 months later, we're seeing these lovely improvements in their functional independence. But I think with time, we'll kind of figure out more of the pathophysiology behind this. So these are just some of the linear mixed models I had put together as part of our research in looking at our SDR outcomes. And we're really seeing that there's significant improvement from baseline in upper extremity dressing, in lower extremity dressing, and upper extremity use, even like buttoning, zipper, tying shoes after an SDR. And then this was the back to the speech piece of this. 77% had a baseline MPT value that was below expected for their age. And by 1 year post-op, they were improving this by 3 seconds, and at 2 years by 4 seconds. And when we looked at this and also normalized it for their age and what we would expect for their advancement, we really saw that the SDR was likely to have been the impact that improved their ability to improve on their speech and breathing control as well. So my takeaway points for everybody: less invasive surgical techniques for SDR are feasible, they're safe, and they produce expected clinical improvements and perhaps even more faster advancements to those improvements because of taking away some of the needed recovery after these procedures. And we're minimizing risk of spinal deformity, kyphosis, and intractable pain while optimizing early participation in inpatient rehab programs. We're also seeing improvements in upper extremity function activities of daily living, and the breath control. And these are going to be really interesting findings to further explore. And I think this is the evidence we're building that, even though we're working on the lower extremities, we're looking at suprasegmental effects above all of this. And the use of SDR and VDR for palliative management of tone, it might produce more, and I say optimal tone management because remember, I think this is very dependent on what a patient's goals are and the goal of caregivers for that patient. And if it increases the ease of care and management for these patients, it's a really important tool to look at. So lastly, I just wanted to show this little picture. I had a pediatrician that got really overzealous because after an SDR that I'd done, the kid wasn't moving their legs as well. And so of her own accord, she decided to get an MRI, which I've never done before. But when this was done, one, I freaked out at first because I didn't know what I was looking at. And then I kind of thought about this. But if you look at this axial view, it's kind of cool. You see that the nerve rootlets in the dorsal region are bright, and you cannot really see the nerve rootlets in the ventral region. So it's a really cool picture of Wallerian degeneration a few weeks after her rhizotomy. So I was very happy to call a radiologist and explain this to them that their reporting of it was incorrect. But with that, I'll take any questions, and I'm looking forward to getting engaged in the cases.
Well, Dr. Marupudi, that was fantastic. Living in the house that T.S. Park built, it's so interesting to get to see the many different ways that people can approach a selective dorsal rhizotomy. I loved your data on it changing speech as well. Obviously, that's the opposite end of where we would expect it to change, but anecdotally, it seems like a lot of patients report those improvements. You touched on a little bit about the role of baclofen pumps and the role of selective dorsal rhizotomy, and the line is very gray and varies between institution and patient to patient, but I was wondering if you could give us hints about how you reason between what kind of patient might be a selective or a ventral dorsal rhizotomy patient and what type of patients would be an upfront baclofen pump patient.
Yeah. So I say, our classic SDRs, the classic criteria that we've already talked about, that fits. But then we're starting to see some patients that are kind of ambulatory. They may or may not, they're a little bit on the older side. Maybe they're 9, 10, 11, 12. And then they're still pretty skinny. They're really small, but they're quite mobile. And they might be losing ability. They might be losing some of their functional strength. And so these are patients where we start to debate, okay, baclofen pump versus rhizotomy. So here, where I can't give you a guideline that one is going to be better than the other. I think it's going to be, all right, family, here's what you would lose with an SDR, but you may gain A, B, and C. And here are the what you might gain with the baclofen pump, but this is what comes with the baclofen pump. You will also have to do A, B, and C, and then these are the potential complications and risks for each procedure. So it just depends on what a family is willing to risk. Are they okay losing the standing function? Or do they want to maintain some tone in order to be able to get their kid up into a stand, or does that help their care? So then maybe a baclofen pump is better. But in some patients, it's just the family feels their legs hurt so much. And in those patients, they don't care about the standing. They just want comfort. And in those patients, the rhizotomy is going to be better. So I don't think that there's going to, and I would go so far to say, I don't think we're ever going to know that one is going to be better for every patient population. I think it's going to be very custom to each patient. And I think I have to highlight again what Jeff Raskin presented. He's customized approaches to a lot of patients. And I think even within the realm of just selective dorsal rhizotomy, we're going to have to do the same.
That's a very, very fair answer. The conversation with the parents about what they want is a long and important one. Does anyone else have any other questions before we move on to cases? I had one other question for you before we move on, not to be selfish, but I was really intrigued by your discussion of leaving some of the dorsal nerve roots entirely intact. Do you have a sense of what your breakdown is? How often are you doing a full sectioning all the nerve roots versus is it all of them that you're leaving a portion intact? And you mentioned working with your physical therapist and your rehab doctor. So I'd love to know how you took that information.
Well, this is a great question, and one I love to expand on. So when we evaluate the child in our spasticity clinic, I ask them to give me target muscles. So we kind of categorize them as primary and secondary target muscles. So primary is definitely need to target these because they're really, really significant tone in them and it's functionally affecting them. Secondary is they have tone, and we don't know if it's affecting them too much functionally, but it would be nice to reduce the tone in those as well. So I kind of target all the primary and secondary muscle groups. Now, in patients who we're just getting rid of tone in all of their lower extremities, I call that the palliative selective dorsal rhizotomy. We're going to go through and pretty much every sensory nerve rootlet, I would take about 75% as long as it doesn't have anal sphincter representation in it. On the other hand, this is that piece where I have some patients that are selective where it's just the gastrocs or it's just really the hamstrings and quads or something like that, these unusual patterns. And in those patients, I'm told, please don't touch this or please don't touch this muscle group because it will really debilitate this child further and it'll affect their functionality long term. Jeff Leonard and I are working on a project where we're looking at our spastic hemiplegic patients. So that's another category of patients where we're looking at just one side, and in those patients, there may be only one or two muscle groups that really need to be targeted so we don't reduce their functionality. So we can get that. We see on the EMG which muscle groups are stimulated by picking up that nerve rootlet. And if your target muscle groups are in there, then I usually take about 75% of that nerve rootlet. And if, let's say, I get a normal response, but it is a target muscle group, I still take about 50% because I'm still trying to reduce tone in, say, the hamstrings or the gastrocs. So I advertise this or discuss this as a very custom approach to each patient, rather than kind of a blanket approach of I'm just going to take X percentage of nerve rootlets.
And that's really exciting. I can't wait to see more and more of your data come out on that. That's a great direction. I'm going to move on to the cases. We're going to do a couple of cases here, still with the goal of finishing up at around 30 minutes after the hour. So we're going to move on to Jared Rowland. In addition to being one of the world's finest neurosurgery partners, he's an associate professor here at WashU and St. Louis Children's Hospital. He's the director of our pediatric surgical epilepsy program, and has been the director of the Pediatric Spasticity and Dorsal Rhizotomy program here. And he's going to be presenting a selective dorsal rhizotomy case.
Great, thanks, Sean. I just started sharing. You guys are seeing the screen, I assume?
Yep, looks great.
So I assumed there was going to be a lot of great information, which there was. I'm very impressed by and humbled by everything I just saw. So I really appreciate that. So I didn't know how much to put in here, and I kind of put a few things, just kind of run through very quickly, but I knew that there wasn't going to be a lot of room to expand on the amazing work that's already been shown. So what I thought I would just show was some of the SDR experience at St. Louis Children's Hospital. I took this on after Dr. Park retired, and I was able to step into the shoes of a giant and an amazing program that he had built over several decades, which has a fantastic group of physical therapists, anesthesiologists, our pain management specialists, and nurse practitioner, physician assistants, a whole team that really kind of shepherded me into this. So I trained here at Washington University under Dr. Park and did fellowship with Dr. Park. So I had done lots and lots of SDRs with him over the years. And then whenever he announced in true TS Park fashion that I am retiring, in kind of a one-liner email to the whole team, I was excited about the opportunity of kind of taking on a program that he'd really championed for so long. So one of the things I was going to show was just a little bit about what that program here at St. Louis Children's had looked like over the years. Some of that was the inclusion and exclusion criteria. Again, hopefully this was, again, aimed a little bit more towards trainees and fellows and people who maybe have heard of a lot of these things or seen some of the amazing science that was just presented, but maybe are thinking a little more of the practical aspects as they're considering developing their own practice in the near future. A lot of variability, as you've heard, of how patients are selected and what kind of surgeries are indicated, but this is some of the general guidelines. Most of these are not hard and fast rules. There's a little bit of flexibility that's allowed in various forms and fashions, but there's some of the general guidelines that we've adopted at St. Louis Children's in our practice. Usually at least 2 years of age. Sometimes people get surprised to hear about that 2 years of age. Sometimes people want them to be a little bit older. But I think, as Dr. Marupudi talked about, we really appreciate that plasticity early on. We really appreciate some of the development that happens, some of the contractures that can happen if left untreated. And so we really see a lot of advantage in the early ages of benefiting from that SDR. Of course, the diagnosis of spastic diplegia, we've had a lot of patients with diagnosis of quadriplegia, triplegia, hemiplegia, and even hereditary spastic paraplegia that we've seen really great benefit. That HSP diagnosis is a really tricky one. We put a lot more consideration and probably stick to some of these criteria a lot stronger, meaning that if somebody's a little bit atypical or something that's a little bit outside of our norm with that HSP diagnosis, we're probably being less adventurous. Whereas with some of the other more classic diagnoses, we feel like we can bend some of these rules from time to time. Some form of independent mobility can range from crawling and walking with or without assistance devices, depending on their age and their expected level of development. Sometimes we're even just looking for core strength and balance and things like that that can show some ability for functional gains. That history of a premature birth, again, goes just to support that diagnosis of cerebral palsy. In our HSP patients or others, maybe we're not looking for those kinds of things. And if we don't see that, then we're really paying attention to all these criteria to make sure we're not missing something, that we're looking at some other kind of pathology that is masquerading. Usually kind of looking for no severe damage in the basal ganglion on MR exam, really looking for that classic paraventricular glomerulation, again, just to make sure that we're supporting that this is the correct diagnosis and we're not looking at a red herring. Some good muscle strength in the legs and trunk is always important so that they can participate in that real intensive physical therapy and rehab afterwards. Really love it when you see their support their full weight on their feet, holding their posture against gravity. Some adequate evidence of motor control or reciprocal movements when crawling or walking in our really young patients, ability to move from one posture to another. That's a lot of the things that we're doing in our clinic as we're evaluating patients for SDR candidacy. Their ability or their current physical therapy routine is something that we think about a lot, especially for those really young patients. That's usually one of the biggest exclusions for those 2-year-olds, is whether or not they're able to participate in physical therapy. If they can't do that intensive training, they're just too young. Sometimes that's one of the big things that says that we have to tell patients, maybe come back next year, or maybe come back after they've had a little bit of development or some ability to participate in that physical therapy, because that's a really important part of the recovery and the outcomes of the procedure. We usually emphasize 4 to 5 times per week for the first 3 to 6 months. A little bit of variability there, especially when we're talking about domestic versus international, how many resources that they might have close to where they live. But it's something that we really strongly emphasize to all of our patients. Some of the exclusion criteria we kind of, again, come up with over the years. We prior intracranial, intraspinal infection. Some of those things can create, again, things that maybe masquerade as cerebral palsy, but can be a really different pathology altogether and really complicate the surgery itself. Congenital hydrocephalus unrelated to premature birth. We've treated a lot of patients with shunted hydrocephalus and they do really well. But something unrelated to premature birth, again, is we think it was like a red flag of maybe there's some other pathology going on here. Head trauma has been a somewhat loose exclusion criteria. I know Dr. Park has done a few of those patients in the past and seen really great benefit. But again, those are just things that really raise the level of concern for you about your patient selection criteria. Familial disease, again, kind of goes on that HSP type of pathway, I guess, of thinking that this could be something other than a different type of pathology, I guess, is the short answer. Mixed CP with predominant rigidity or dystonia, you've already heard that multiple times throughout the prior talks. Severe scoliosis for a variety of reasons that you've already kind of heard in the earlier talks. And the not expected to make functional gains after surgery. That's another one that, again, has a lot of flexibility there, especially when we're talking about that palliative benefits of SDR. If you're not expected to make functional gains, that's kind of where we typically define palliative SDR, where it's looking to make other things easier, maybe less pain, caregiving improvements and things like that. But if it's not functional gains, that's kind of how we define palliative SDRs. Those are the general criteria. Those are generally good things that if you're in that resident or fellow kind of training stage and you're looking to have a little bit of guidance as you're starting this program for yourself, I think these are good places to start. And then as you've already heard, there's lots and lots of ways where you can expand on these or take them in other directions. But those are some general guidelines that we've used at St. Louis Children's. Some of the demographics, again, these are all from Dr. Park. He retired in June of 2024. So several decades of work and several thousands of patients. His, again, kind of we emphasize that early timeline. You can see the vast majority of those patients are ranging from 2 to 6 years of age. I think this is pretty similar to what Dr. Marupudi presented in her practice. But Dr. Park also had a big practice, or a reasonable practice, on the adult side. As I've taken on this role, I'm personally not treating adult patients, but this was something that Dr. Park did see some benefit on. It turns out they're very, very challenging. There's some unique considerations there. The outcomes and complications are really a totally different beast. The anticipation or the expectation of what those I won't say complications, maybe side effects of that rhizotomy has when you're at that age is something that you really, really have to prepare patients for if you're going to take that on an adult population. But you can see the vast majority of our patients over the years have been in that 2 to 6 year age range. Looking at the gestational age for most of these patients, again, largely premature. There are some who are over 39 weeks. And again, those are those ones that kind of raise your level of concern to ask, am I missing something? Is this maybe an HSP type of pathology? Is there something else here that's going to kind of take away the benefit of an SDR because it's a different pathology altogether? The vast majority of them were spastic diplegia. Dr. Park's numbers were 76% overall, but a fair number who had diagnosis of quadriplegia, hemiplegia, triplegia, and others. Some of these hemiplegic patients were actually some of our prior functional hemispherotomy patients, and we saw really great benefit after they've had the excellent seizure outcomes from a hemispherotomy. They might be left with some spasticity, and having that unilateral SDR really showed some impressive benefits in those patients. So it was a really interesting kind of patient population to apply this technique to. The mobility level, again, a variety of ranges here. Vast majority of them have some level of walking with a walker or independent walking. Some of those no independent walking at all. Those are some of the more palliative kind of procedures, and you can see that was a relatively small percentage of our practice over the years. The general procedure, you've heard a little bit about these. This is what we traditionally think of as Park's innovation over the years. This 2006 paper by Dr. Park and Jim Johnson is just a fantastic paper. So I'm really just kind of walking through some of the figures here because it does such a great job of spelling out the way he did his procedure. Prone, Slide-Trendelenburg, that figure's maybe a little bit exaggerated, but Slide-Trendelenburg. A little bit of an old example of an ultrasound, but this is one of the things I love seeing Park do, would be localizing the conus with the ultrasound, especially in really young patients, that kind of 2 to 5 year range. You can see it really well through the skin, through the kind of interspinous space. And then once you do your initial exposure, you take down some of that interspinous ligament, you get a beautiful view of the conus. This is an incredibly old figure of the ultrasound. I need to update that, but it did a remarkable level of making sure you're at the right level to come down right on the conus. A single level laminectomy, as you've heard about, isolating those dorsal nerve roots using that blue slot that Patty that you've already seen several times in a couple of videos today, isolating those nerve roots using your EMG neurophysiology testing, again, that you've already heard of, so kind of moving through these things pretty quickly. Our grading scale, where we're kind of marching through those nerve roots, deciding which ones we're going to section and which ones we're going to spare. Our general approach has been about 2/3 of the nerve roots we would usually section, divide each of those roots into 3 sections, cut the 2 that have the greatest contribution to that spasticity. That's usually the way I describe it to the patient's families, and spare that that has the least. Pretty consistent technique there. One of the things that I've also loved about the kind of one of the things that Dr. Park innovated over the years was putting an epidural catheter in place at the end of that procedure. So after you close the dura, putting that epidural catheter in place under direct visualization, tunneling it out laterally, and we use that for our pain control for the first 3 days. We're usually having them on bed rest for those first couple of days, and on day 3 it just slides right out, and that's the first day that they get up and start their intensive physical therapy after surgery. That's been a real game changer just for pain control after surgery. I have a quick operative video. Honestly, I'll probably skip it because you've seen great videos of these all together. And just in the interest of time, I'd like to get to Bernardo's case, but it's very similar to what you've already seen and what's in those figures. If anybody has any questions, I'm happy to jump to it and show any kind of parts of the technique itself. But otherwise, that's kind of the highlights of what we do at the St. Louis Children's SDR program.
That's fantastic, Jared. I always like getting to see those big summary numbers. Was it 5,232? Is that the final?
Yeah, 5,232 was Dr. Park's final number. My number as of last week was 23, so I get to say I'm half of his number. I think that's how math works.
So for our last presenter tonight, this is Bernardo Domanico. He's going to be presenting a short case involving a baclofen implant patient. So Dr. Domanico already has a very well-accomplished career in Brazil. He did his MD, his neurosurgical training, and his PhD at the University of Sao Paulo, possibly the premier medical institution in Brazil. He was an attending physician there for a decade, doing pediatric neurosurgery, as well as a very, very active and very broad functional neurosurgery practice across all ages. He's came to the United States to do functional and neurotrauma fellowship at the University of Miami, and is joining us this year to do a pediatric neurosurgery fellowship. So thanks, Bernardo, for taking time for us tonight.
Thank you, Dr. McEvoy. Thanks, Dr. Roland. I'm learning with Dan Washu. Happy to be here showing a case. I'm going to be fast. I know it's late. So this is a born full term in northwest of Brazil. It's a very poor region in the country. The child was born with severe neonatal jaundice and was treated just with some bath, no transfusions. So he got some delayed more milestones, spasticity, ataxia, and dystonic movements. He was referred to the University of São Paulo with about 14 years old. He had no seizures. His cognitive function was preserved. Normal ceruloplasmin, so no Wilson disease, and the genetic panel there was limited, so we don't have much information about that. So the diagnosis was like encephalopathy because of the neonatal jaundice, so kernicterus sequelae. Neurology did like the clinical management of the case using baclofen, diazepam, Artane, and non-responsive to levodopa. And they were doing some injections of the botulinum toxin. The patient was referred for us with about 16 years old. This is the patient. He was dependent for all daily activities, including get dressing, to eat, to do his physiological functions, for everything. I was asking him here to grab my hand, to try to shake my hand. He was completely unable. He dropped his pillow. When he tries to do some voluntary movements, his movements get worse. And he was classified as one of those mixed movement disorders that includes dystonia, dyskinesia, and the spasticity. So left lower extremity, I was able to move with some spasticity, but it was an Ashworth 3. And his deformities were not established, so I was able to reduce. On the right lower extremity, it was an Ashworth 4, so very, very spastic, GMFCS 5. So his MRIs were likely normal. We cannot observe any hypersignal on the thalamus or on the dentate. Maybe on the right dentate, we have some hyperintense signal there, but the read was normal. So we proposed those procedures for him. The DBS was not available for CP children there. My choice was doing pelidotomy, but he was against doing a polydotomy, thinking in doing a DBS in the future. So we went for the intrathecal baclofen therapy. And this is a 3-year follow-up. The patient, he got much better with the involuntary movements, and he is still having some movements and some dystonic tremor, ataxia. And but the spasticity, of course, improved a lot with the intrathecal baclofen therapy. This is the right lower extremity that I wasn't able to move. Now it's completely loose, Ashworth 0. And now I can ask him to shake my hand. He has some difficulties, but he can reach the target. And he's using compound baclofen, 4,000 micrograms per cc, and we are using a flex flow rate. And I've been using flex flow rate for a lot of patients. and his catheter is cervical, as Dr. Jeffrey told in his lecture. I like cervical catheters as well, and intraventricular as well. But this case I did before starting doing my intraventricular pumps. That's why it has a cervical. That's the case I'm happy to talk more about. I know we are late, so that's it.
Thanks so much, Bernardo. That's such an impressive video. It just even feels more comfortable to watch him after he's had the pump compared to preoperatively. I think we're finishing up. Does anybody have any last questions that they'd like to ask any of our speakers before we close out for the night? Okay, well, thank you to everyone for joining us. It was such a great time getting to hear from all these speakers. It's definitely going to affect how I approach these patients in the future. Thanks so much.
Good night.
All right, good night.